Welcome back to the Canadian Fall Prevention Virtual Conference, Day 4. I'm Hélène Gagné, the Program Director at the Ontario Neurotrauma Foundation and your moderator for today's session. Before we get started, I have some quick housekeeping items to run through. So we have muted each of you, but we encourage you to use the Q&A box to ask any questions you may have during the presentation. There'll be time for questions at the end of the presentation today. We have our IT team standing by in case of any technical difficulties, so please let us know in the chat box if you are having any trouble with visuals or sound. There'll be a short survey at the end of this session, so please don't log off, stay on. Your feedback is greatly appreciated. We would like to begin by acknowledging that the Parachute Office is situated upon traditional territories. The territories include the Wendat, the Anishinaabeg, the Haudenosaunee, Métis, and the Mississaugas of the Deux Credit First Nation. As this conference is taking place virtually, we would like to invite all attendees to learn and reflect on what First Nations, Inuit, or Métis land their offices or home might be located on at nativeland.ca. We would also like to thank our gold sponsor, Brown Healthcare, home of Hip Saver Canada, the exclusive Canadian distributor of the world's leading hip protector, for their generous support of the Canadian Fall Prevention Virtual Conference. You can check out your delegate package for more information on them. Parachute would also like to thank our bronze sponsor for today's sessions, the Ontario Neurotrauma Foundation. So now let's begin. Day 4 of the conference looks at vulnerable populations and special considerations in falls across the lifespan, with a special focus on Indigenous peoples. We have 2 presentations today in store for you over the next hour and a half. This session is a little bit longer than the sessions that you've attended so far at the conference. So please stay tuned, don't leave too early. And first, we'll have Dr. Vikki Scott will speak for around an hour, followed by myself with a short presentation. Unfortunately, it was supposed to be Dr. Kathy Belton today to do the second presentation, but she's not feeling well, so I'll be presenting on her behalf. As always, there'll be time for Q&A after the presentation is complete. After Vicky's presentation, we'll have some questions right after that. So let's start. It's my pleasure to introduce our first speaker, Dr. Vikki Scott, who is a clinical professor with the School of Population and Public Health at the University of British Columbia. She has led or co-led over 40 studies on seniors' mobility, fall, and injury prevention. She is the lead for the Canadian Fall Prevention Curriculum and author on 29 peer-reviewed publications, numerous technical reports, and the 2017 book on fall prevention programming. Dr. Scott is also co-chair of the Indigenous Fall Prevention Network. Please welcome Dr. Vikki Scott for her presentation on Pan-Canadian Fall Prevention Training, Current and Future Opportunities. Go ahead, Vikki.
Thank you, Hélène. And thank you to the conference organizers for this wonderful conference and all the work that goes behind that. I'd like to acknowledge that I live, play, and work on the land's unceded territory of the Sinamo First Nations people in the Salish Sea on the West Coast. So hello to everybody and welcome. I'm going to talk about Pan-Canadian Fall Prevention Training, Current and Future Opportunities, in particular 3 programs: the Canadian Fall Prevention Curriculum, Strategies and Actions for Independent Living, and an adaptation of the SAIL program for First Nations, with the emphasis being on the last. I'd also like to acknowledge a number of organizations, and I'm just trying to figure out how to forward my slides here. There. I hope you're all seeing the acknowledgements page now. I have a couple of screens going here. But I'd like to especially thank supporters and the participants who made the development of the 3 fall prevention training opportunities possible. The public health.
Vikki, can I interrupt you for a second? We're not able to see your slides. Can you try again?
Okay. I got 2 screens going. How's that? Is the acknowledgements page showing now, Hélène?
No, not yet.
It's showing on my screen. So we'll need to go to the technical support then, Elaine, because I'm seeing it on the screen when we do our
Vicky, are you sharing your screen?
Let me go make sure that I didn't get bumped out of that sharing. And just a sec. I have to go back to this screen and PowerPoint. I thought I had shared Michael, but I guess it got bumped out. Okay.
There you go.
Okay, so now you're seeing it?
Yes, we
Yes.
are.
That's working now.
Great, thanks. Okay, so I'm now moving on to the acknowledgements page. And as I said, thanking many supporters and participants of these three projects, particularly the Public Health Agency of Canada, Universities of BC and Victoria, the BC Injury Research and Prevention Unit, the First Nations Health Authority, and the Centre for Hip Health and Mobility. So I'm going to start with the Canadian Fall Prevention Curriculum, and many of you may be familiar with this course or have taken it, and I won't spend a lot of time. It's been around for a long time and is still taken every semester by many people through the University of Victoria. And this is for health professionals who want to design, implement, and evaluate an evidence-based fall prevention program. And it builds on the experience and training that you already have and brings you to ability to pull all the information together and use a multi-sectoral fall prevention approach tailored to individual seniors or communities. So it's for acute residential care or long-term care, home care, or with the well elderly in the community, as well as First Nations or Indigenous communities. And there are case studies that address each of those populations. So you can really tailor this course to your individual setting. It is based on a policy and social and policy context where you define the problem, identify the risk factors, examine best practices, you learn about implementation based on implementation science evidence, and you learn to evaluate the program. And all of this in the social and policy context, which means you learn how you can implement that program in your setting and understand the challenges and the strengths of being able to do that. And it's an iterative process, not a linear one. It's also very much based on an interactive fall risk model, where it used to be thought that risk was either environmental or biological or intrinsic. And we now realize it's very much broader than that. It involves behavior, and that's not just the behavior of the older person, it's also the behavior of those who work in the healthcare system and learning when the optimal times for change and how to bring about change and how to know about readiness for change and motivational interviewing for change. But it also recognizes social and economic issues. And so right now, a huge social issue is COVID. And when you think about fall prevention in the time of a pandemic, we realize that it's really important to keep our older adults out of hospital and to keep them safe and secure. This is not the time for them to be having a fall-related hip fracture or head injury or anything else. And so how can we best do that even in this particular context? The CFPC, or Canadian Fall Prevention Curriculum, for the prevention model relies on what we call the BEACH model, which is the first letter of all the parts, beginning with behavior at the center. And we really feel that is core to bringing about any change. But we also look at equipment, education of the health professionals, education of the adults, education of family members and policymakers. We look at the environment, indoor and outdoor, activity, exercise, but social activity as well, keeping the mind sharp as well as the body, clothing and footwear, and health management. And health management, of course, is a large section on how people can best keep themselves in their optimal level of health, and health not being the absence of disease, but the overall wellness and self-perception of health and how to maintain that. So that's all I'm going to talk about, just to let you know that the course is offered each semester through the University of Victoria at the link given. The next course starts in January 2021, and anybody that would like to be on the list of distribution of course notices, please let me know. I'd be happy to add you to that list. The textbook for the course, but also a book that is a standalone book that you can use to help design your own programs, is available in both English and French. Now I'll move on to the strategies and actions for independent living. So in the CFBC, we talked about designing, implementing, and evaluating your own program. Well, this is such a program that you could design, but this one's been done for you. And this is a program specifically for older adults who are frail and living at home. And it's specifically for people who provide publicly funded home support services, but it's relevant for anybody who's working with frail older adults living in the community. So the learning outcomes. And so for those who take this course, by the end of the 3-week course, you'll be able to apply a specifically developed 3-level home-based exercise program that includes videos, handouts for client use, and training for you on how to motivate and support clients to use the program. This is a very popular program. We developed this here in British Columbia, and now it's going to be offered internationally, but definitely with a focus on Canada. And it is for frail older adults who cannot get out to go to group exercises or would augment group exercises, and particularly relevant right now when so many older adults cannot get out. And this is a good way to keep them mobile and active. And I'll show you some examples in a minute. The second learning opportunity is a detailed risk factor and checklist action plan with numerous strategies and actions to reduce risk. And this is over 60 risk and prevention strategy combinations that deal with all the aspects of health, environment, footwear, clothing, lighting, etc. And it asks the client for them to self-identify where they see their greatest risks. And it provides suggestions for prevention. So it's not a top-down health professional tool. It's a self-directed, client-centered tool where they have the ability to self-identify where they feel they're at risk. And the role of the health provider, the home support aide, is to help them achieve their own goals. And finally, the SAIL program includes fall tracking and reporting tools. And these include a calendar, which I'll talk about later, and a fall report. So it's very much a team approach, very much client-centered in that team approach, or a family member where appropriate. And preventing falls requires members to work together, the team being the client, the home and family, and the home care aide, and the health professionals who work in home support. So that could be nurses, occupational or physical therapists, or others who may work in home support. So a little background on the SAIL research. When we conducted a controlled trial over 6 months, we found that 82% of the falls occurred inside the client's home. Now that's not surprising given we're talking about a frail population who receive home support services. 37% occurred in the morning, which is an important finding for allocating time, home support service time for the older adult. And most falls were unobserved. And that's not surprising, but many home support agencies were only dealing with falls that were observed. And that was a very small percentage, and not really realizing how many were happening otherwise. And home care aides and home health professionals trained in the fall prevention were able to reduce their clients' falls by 44% over 6 months. So when we talk about behavior change, we really see it as the most important part of the client-centered approach. And the way it is that, and the approach is to understand the best ways to help the client make positive changes in their behavior. For fall prevention strategies to be successful, we need to concentrate on effective communication skills and understand when our clients are ready to make change. And when we talk about fall risk factors, it's important to know that most falls occur in individuals with multiple risk factors. In fact, community dwelling adults age 65 and over, the percentage of persons falling increases from 8% for those with no or one risk factor to 78% if they have 4 or more risk factors. The important point is to note that risk is cumulative. The risk for those with 4 risk factors is greater than 4 times the risk for those with 1 risk factor. So we start off with the client completing a fall risk screen. This is a validated tool for determining the level of risk and specific risk factors. It's best to complete this screen with your client during their orientation to the SAIL program, and this way you'll have a sense of their level of risks. It gives a level on 1 to 7. And you can discuss specific risk factors that they identify. The screen is also can also be repeated after changes in health or after prevention strategies have been put in place to see if their risk decreases. The second set of tools are the calendar and the fall report. And this has been tested many times for content and feasibility, and meaning that we wanted to make sure everything was doable within regular home support service without adding on very much time other than the orientation. And so this calendar is client driven, and we suggest it be in a visible place. And the clients are asked to put a check mark every day they do not have a fall. And that was a suggestion that came out of an early study where a client said, I'd like to see how well I'm doing, not just how badly I'm doing. And then if they do have a fall, they put an X. And when the home support provider comes into the home and they see an X, together with the client, they fill out the fall report, which asks about the time, place, and circumstances of the fall and any injury that occurred. And if it's a serious fall, this goes back to the home support office for follow-up with a health professional. And the home support office can also use this for tracking. They can find out when are falls happening, who are the frequent fallers, what's the pattern of falling, what are the contributing factors. The next tool, the Checklist and Action Plan, or CAP, is an interactive tool where the client is asked a question that triggers a no answer, and this is based on research that shows people like to say no more than they do yes. And that no triggers suggested interventions. And so this is a tool the client can do on their own, or if the home care support staff have the time, they can do it with them, or the family can help. And it's not just done right away, it's just done over time. And so an example of how this might work, if the home support staff member is there, they can talk about falls that happen in the bathroom or risks that are associated with the bathroom while they're giving them a shower, or helping them when they're in the bedroom, talk about the bedroom and their sleeping patterns, etc. So it's meant to be woven into regular practice in a way that's very conversational and awareness raising. The home activity program I spoke of earlier has 3 levels: sitting, standing, and moving. Each level has 7 different exercises. And it's up to the agency whether they decide they want to assign someone to screen a person's ability to do exercise, or they can even tailor exercises to that person, where they could choose some from the sitting, a few from the standing, and if the person is up to one or two of the moving, they could have a custom designed program. Or these are designed to be safely used by the client, but the videos and the handouts that come with these have client instructions to say that if they have any health problems or they're concerned or have any pain, they must consult with a family physician before doing the exercise. But they are designed to be safe and easily done at home, and always next to a counter or something they can secure that they can hold on to, or in a sitting position. And this slide just shows 3 examples, one from each of the levels. And you can see how it's always done next to something they can hold on to for safety. And the videos walk them through how best to do each exercise, remind them to do slowly, to start with only a few repetitions, to build up, to stop and see if they're feeling okay, and only carry on if they are. So safety is built into all of these exercises. And so in that home activity program, as I mentioned, there are videos for the clients and handouts. There's also what we call the Hap Tracker. And this is a motivational tool where the client can check off how often they do each exercise each day. And then they can show that, if they choose, to the home care support worker that comes in, and that's show them how well they're doing, or maybe they need some encouragement to do more. There's information for clients and their families. And then there's training for the home health professional. So there's a video on how to introduce these exercises, how to do them safely. And there are suggested screening tools, what you can do to see if that person's mobility allows them to do certain exercise, and how to use those tools again to see how well the person is doing. So that's the SAIL program, and it's once again offered each semester through the University of Victoria. This is new. It's only run once so far, and it was very successful. A lot of good feedback, and it's going to be offered again in February and each semester. So if you have any questions, please type them into the question and answer section, and we will deal with those later. And now I'm going to move on to the SAIL for First Nations. And at the end of this presentation, I'm going to ask you to specifically provide some feedback. When this conference was first planned, it was going to be in person in Saskatchewan. I was so looking forward to meeting up with all of you there. And we were going to have a special workshop on this project where people could work in small groups and give feedback and come up with suggestions, but it didn't happen. And at this time, I should just stop and ask Michael to put out a survey, a poll rather, so I can find out where you work and how many of you work with First Nations older adults. So Michael, I meant to do that earlier, but if you could put that poll up now, I'd appreciate that. And if you could all just check one or more of these categories, so I have a sense of who's online and how I can best relay this project to you. So I'm just going to stop for a minute, and hopefully you can complete this poll. Okay, and while you're doing that, I'm going to move on to the next slide. Now, Michael, it looks like I have to click the poll myself to move on because it's on my screen, but I'm not sure. Okay. So we'll just wait for those poll results. It seems I can't move on till that comes through, but I'm looking for the results soon.
Vicky, it's Elaine. I just want to let you know that in the chat room, some people were saying some of them work in public health, regional integration lead, community and acute care, home care, and my clients include First Nation and non-First Nation individual, Osteoporosis Canada, public health, just so you know.
Excellent. Thanks for that, Ellen. That sounds like we have the right audience to be providing some feedback. That's great. Okay, so Michael, can I move forward now? Yeah, okay, there we go. So I'm going to talk a little bit about the background of SAIL, why that's coming in. And so the scope of the problem. So when we talk about First Nations communities or Indigenous populations, there's a study done in British Columbia to show it's the leading cause for older First Nations people of injury hospitalizations, and this exceeds motor vehicle crashes. And we also found that fall injury rates for Indigenous populations were twice those of non-Aboriginal populations, including hip fractures for falls. Okay, so I've just got the poll result, and we have 30% healthcare providers, 3% health administrators, 15% policymakers, 17% researchers, no teacher or professor, primarily working in large urban centers, 22%, rural and remote areas, 25%, and primarily working with Indigenous populations, 3%. And then others, that's what you were reading, what that Ellen, the others that we're sending to the chat, I think. So that's a good variety. I'm glad to see we have that balance of urban and remote and rural. So that's great. And third, healthcare providers. Excellent. Thanks for that, everybody. So yeah, so just talking about that scope to know this is a greater problem for Indigenous older adults than non-Indigenous with regard to hospitalizations and injuries. And so what happened originally was the SAIL program was operating in British Columbia. And I received a visit from two members of two different First Nations bands in British Columbia saying, we like the program, but it is not working that well for us and how we offer home support. And then we applied for a grant and got some funds to adapt it. And so what I'm going to show you here is the adapted version based on that project in British Columbia. But what we'd like to now do is adapt it for across Canada, for a pan-Canadian version. And that's what I was hoping to do at that workshop, but we'll do our best here to see if we can get some input. So the consequences of falls for elder adults are the inability to diagnose or treat injuries in some communities. So for example, if there's a suspected hip fracture in some communities, sometimes the older adult has to be air vac'd out. They have to leave their community, and it may not even be a positive result, but the disruption, the social, economic cost of all that can be huge. There's the separation from the family and the community when people are asked to leave for medical reasons due to fall injuries. Often there's a lack of cultural safety in the services that are provided away from their community. And that can be anything from discrimination to just not having their foods they're used to, language barriers. Many, many things are part of cultural safety. There's a fear of dying away from home. It's very real for a lot of the elders that I've talked to. A lack of resources and support to function independently at home. And even the design of many homes. There seems to be almost a standard design where they're all built with large, steep staircases and very little area on entering the home, many trip hazards, very poor designs in many cases, and then just the maintenance of homes and the finances to do that. There's often a lack of rehabilitation and occupational services. And then there's reduced mobility due to fear of falling again, and that's very real because of the consequences are so severe. But there are also many strengths that exist within First Nations communities. And I was able to witness this firsthand because with this project, we conducted, as I'll show you later, workshops that were all in different areas of the province. And then I would go back again to do a site visit to 8 different sites, some in very rural, remote areas that I'll talk a bit about and some in more urban centers. But the strengths we found was a great respect for elders in general across the community, but especially among family members, and the close family ties that existed that would go back, and across generations, and really like the communities were a family themselves. And there was a lot of strength from strong spiritual beliefs. Community belief in the obligation to provide support to the elders. Another feature that was very positive compared to the non-Indigenous populations was there was a very low turnover in the home care assistants. They tended to be part of the community. They knew the elder person very well, almost considered like nieces or grandchildren. And so the communication was very open. And the home assistants typically lived within the community, and they know their clients well and have for many, many decades or generations, in fact. So the project goal was to adapt the SAIL program for cultural relevance and local application. And that local application was important because each community was different, and the Indigenous communities had issues that were not that typical of non-Indigenous communities, and I'll talk about those. And develop in response, this, as I mentioned, was developed in response to an invitation from the two bands that identified this as a priority need, and that was important. It was self-identified as their priority, not something that they were told or suggested they do, but they asked that we come and work with them on their leadership to do this. The project took place over 5 years in 5 stages. We had an advisory committee that consisted of elders, that I call elders with a capital E, that were the people who are recognized in the community of having the wisdom, the historical knowledge, and the ability to speak for their communities. We had training workshops in 7 locations, site visits, which I mentioned, and then a meeting where we brought the key people from across the workshops and training sites to talk about how well they felt this project was adapted, how well they were able to implement it in their communities and have it become part of their permanent way of being. And then the final product, which was shared back with all the communities through the First Nations Health Authority. So the philosophy is that the most important part of fall and fire prevention, which was one of the adaptations made based on the request that when you're going into the home to look at fall hazards, why not look at fire hazards at the same time? So the most important part of fall and fire prevention is respect for our elders through a shared learning of their risk and supporting their choices for risk reduction. Another important aspect was to look at the larger context. And what I mean by this is, and this comes from the work of Charlotte Redding through the Indigenous Cultural Competency Training, is to remember that the distal determinants are still very much a part of what's happening now in our Indigenous communities. And this means that the impact of colonialism, the Indian Act, the residential schools, and policy decisions have all led to the existing poverty, economic insecurity, inadequate housing, and racism, and that those determinants are now impacting many health outcomes, and only a few are mentioned here, and we've added falls and injuries because we see a direct correlation. So a lot of the risks come from those original determinants, and that needs to be considered as you work with these populations and to learn from their experience, to learn from the strengths that have come out of the challenges, to learn from the negative impacts and how they're working to resolve them, and how that impacts how we work and make change with them from their perspectives. So the training portion was for home health assistance on fall and fire prevention, and this is one of the groups in one of the communities. And we ended up calling it the SAIL for First Nations projects. And one of the first tools that we developed that did not exist in the original program was a tips for elders on fall and fire prevention. And this was used in a number of ways, just as a handout that would be given out or made into a larger poster that could be in a center where elders gather. And it was a good discussion point to get the topic going. The calendar is much the same, although the images have changed. The fall report, we asked if they wanted that changed, and no, most of that still applied. There were a few minor changes made and some images. But what we did is we asked during the training and at the site visits and through the advisory committee for changes as we did the 7 workshops. And each time we were given changes, they would be analyzed and looked for ones that were repeated, and we made changes after each workshop. So each workshop became more adapted until finally the 7th workshop, then all the materials were given to the participants, and the workshops represented many bands across the province. So there are 203 bands in British Columbia, and 71 altogether were represented in the 7 workshops, and they all got the final product. And it was a train the trainer model where they would go back and teach the home support providers in their communities after they were trained at the workshops with these changes made. Changes to the home activity program, because of the budget, were not possible to redo it with Indigenous people, but they said they were fine with that. It's still applicable to them from their point of view. But what we did find is that they wanted other products that would work to help bring fall prevention in a way that worked best with their communities. And we called these the enhancement products. And so we took the fall risk screen and we adapted that, changed some of the questions, but the core screening, or changed the brochure content, but kept the same screening, the validated tool. We're not asked to make too many changes to these tools, but we did adapt them somewhat, but they definitely wanted to use these 3 assessment tools: the timed up and go, the sit to stand, and the 4-stage balance test. They found those very helpful, especially before and after introducing the exercise. Another addition, and this comes from the Fraser Health Naklatmuk bands, and they had their own fall prevention project happening, and then SAIL came in and became part of that. But one of the products that they developed that we asked to borrow from them was this bingo game. And so with the original SAIL training, it was just for staff. When we did it with the First Nations bands, they said it's a 2 or 1.5 days of training. They asked that the second day involve the elders, and then that the home support staff who were trained on day 1 would in turn now apply that training to the elders. And bingo was one way to do that. And all the questions were about fall risk and fall prevention, and there were prizes, and it was a lot of fun. Another request, and this was one band in particular, the largest band in British Columbia, called the Cowichan Band. And they said they would like to have a group exercise because the elders tended to gather in this special center that they had, a large space, where they would have elders' lunches twice a week. And so we did a review of the literature, and the most effective group exercise is Tai Chi, and there's good evidence for that. So we found an instructor and did a special project in the Cowichan Band for Tai Chi, where we did all those 3 tests and other measures before and after, and there was significant improvement. And then we also produced videos. So the Tai Chi program is instructional videos and handouts for all the exercises. And it's just based on 7 Tai Chi moves that are shown, if done, on a regular basis to significantly reduce the risk of falls. And we also wanted to understand the meaning of this to the elders. And so we interviewed them before, after, and during the Tai Chi project. And we produced a video. And I highly recommend it if you haven't seen it, and that's the link online. And I think if you even put in elders motivational Tai Chi video, you might come up with it if you haven't got time to write down the link. But it's very powerful video on the positive and challenges aspect of learning a new exercise, and I highly recommend it. So now I'm going to switch quickly to talk about our evaluation of this program. And so our goals were to determine success in adapting the program for cultural appropriateness and local application, the reach of the training among the bands, the effectiveness of the workshop in developing knowledge, skills, and confidence to deliver the program. Remember, it's a train the trainer program. Implementation of resources in participating communities. So how well did they take that learning and those resources and then implement it once they got back to their communities, and the spread of the training to others. And so here's a map of British Columbia, and the colors are the health authorities, and they were partners, but really I think a better map might be a map of the First Nations. And there are many different First Nations in British Columbia, language groups that some overlap, and they don't have boundaries with, they spread over into Alberta and down to Washington State. But anyway, here's where we did our workshops. And then when we went back for the site visits, they tended to be in some of the remote communities and some of the urban centers around these areas. Remember, there are multiple bands that are represented at each workshop. And what we found, looking at who attended, so we rep 71 bands. When we look at those 71 bands, they represent over 42,000 people. Over 6,000 would be age 65 and over, and equal numbers of male, female. So that's our potential reach to older adults through those 71 bands that were represented by the trainees. And the trainees, 89 in total. And then we're interested in their ages and their number of years in the job. So quite a spread in each, but there was a lot of experience in the room with people who had been in home support for a number of years. And that was very valuable to us to get feedback, to make changes to the program. And so staff training, we did a pre-test of knowledge on falls before and after, and there was a 61.5 increase in the pre-post test result. And then there was an average of 4 out of 5 for implementing the program. Their confidence, there's a high rate of confidence of them to be able to do the training of the trainers, to go back and do the training in their own communities. We got feedback on the images, the kind of images they'd like to see. They told us about challenges that with their communities, such as people needing to travel by boat to go to medical appointments, or during a medical emergency being evacuated by float planes, how slippery the ramps were down to docks, how unpaved roads and unpaved walkways provided hazards in many communities. They asked us to format the calendars so that it could be edited for local events, such as adding events for elders in their communities. So those are a few of the many changes. And so when we looked at the program, modifications were made from feedback on questionnaires, interviews, and focus groups that occurred with clients and their families, support staff and managers, and the advisory committee. So myself and sometimes with others, we'd go into the community after being invited and had the great honor of meeting with groups of elders or being invited into elders' homes and actually doing home inspections for hazards and talking with them about the challenges of fall reduction and getting their ideas of how that could be done. And so the modifications, here are all the resources of the modified SAIL program. And so the staff training was modified considerably, as I mentioned, going from 1 day of training to a second day, half day being with the elders. That was a big change. We changed the checklist to really reflect the environments, the conditions, and the health challenges of the Indigenous populations. We modified the calendar. Fall report and database, no change. Home activity program, no change. Mobility assessments were added and edited for clarity. We added the fire and fall prevention handout. The fall risk screens were added, Tai Chi and bingo. So a lot of changes were made, but not to everything. I think I talked briefly about the pre-post test increase. That was significant. Confidence on a scale of 1 to 5. The only one that we noted, the home activity program, that was at 3.89 out of 5, was a bit low. And so we put more emphasis on that as we moved on. And then self-rated ability to conduct activities, a score out of 1 to 3, all were 2 to over 2.5 for some. So there was a good level of confidence going back to their communities after the training. However, when I went to the communities for the implementation and looked at the implementation, I didn't see so much confidence. And what we found when we got to the communities and interviewed people where they live is that we really needed to pay attention more to the family, to the local culture, the community as a whole, and to the aspects of spirituality. And we realized that we needed to spend more time on leadership and planning. So we had the home support leaders, the home support providers come to our workshops and give us feedback. We had an advisory committee, and all of that was very helpful. But what needed more time on was spending time with the chiefs and councils, the local band leaders, others who work with elders in their communities. We needed to work more with the administrative support to make this happen. Who is going to print the materials? Who is going to distribute them? That kind of thing. And on top of the staff training, we found that we needed to build in more coaching. And what I mean by that is sort of having a mentor. And once the person was trained on the program, have them go with that person and see how they're doing and get more feedback from them. We needed to spend more time on documented accountability. You know, how many clients were receiving the programs, what were the challenges, and then documenting and talking about how they could be overcome. And we realized that we needed more monitoring and improvements. The biggest challenges, of course, being adaptations to the homes, putting in ramps, fixing staircases, and understanding where budgets were come from to do that, and how funds are allocated, who gets to have those changes made to their homes, and who has to wait, or maybe nothing happens, and what are some external sources of funding that could be used, like the Home Adaptations Project, HASI. So we were able to help them find some funds for that. But that really led to the fact that it's great to have enthusiastic people who really want to come and learn new things and really understand the science behind the evidence and wanting to apply it, but realizing contextually there are many challenges. And of course, these challenges were not just for the SAIL program. These challenges were for any health promotion program that the First Nations people would like to have implemented and want help doing. And as I mentioned earlier, it's all within the larger context of those distal and intermediate determinants that influence this, and having time to reflect on that and work with the elders to really understand how we can help them and they can help us to do this. And so out of that, we developed a step-by-step guide on how to implement the program from that learning. But to adapt it now, to have it be a true pan-Canadian project, I feel we need to understand those issues on a national level so that we can further adapt this program. But also, it's not so much the minute content, although that's important too. That this only represents First Nations communities in British Columbia. How can we adapt it? And this is what I was hoping to do in person at a workshop, and this is going to be a lot more challenging online. But I do want to pose some questions to you. And unfortunately, given the number of people, we can't have an open discussion. So please, with each of these questions, I ask that you come up with any thoughts that you have, instant thoughts, or even if you have some later and want to send them to me, I'd be happy to have them. But these are the questions I'd like to pose to all of you to help think how we can adapt the sale for a pan-Canadian version. So first of all, how can we engage older Indigenous adults and senior community members? So as I mentioned, in some cases, and terms are different in different communities, but chiefs and councils and band leaders, how can we engage those key stakeholders as role models to champion culturally appropriate choices and approaches to fall prevention? So any thoughts you have that you can share with us on how to engage older adults and leaders, champions to make these adaptations? How can we reach out? What would be the best way of doing that? Who should we contact?
Well, people are putting their thoughts in the chat box. I'm assuming that's where you want to see that, Vicky.
Mm-hmm. Yes, please.
We have a very quick question first. Somebody had asked how are the videos supplied?
So this program is not yet available. We want to adapt it, and then it'll probably be through the University of Victoria. So the sale program is already there, and we could have a version that's for Indigenous, but I don't know yet. And that's another question. How would people, see this being made available? And we're going to talk later about you're going to talk later, Ellen, about the Indigenous Fall Prevention Network. But, there is a cost to doing adaptations and hosting, and we don't just want to throw out one part of the program. Like we feel strongly that if you're going to implement fall prevention exercises, you need to understand about the evidence for fall prevention and how exercise is just one part of the bigger picture. So we don't just want to throw out one piece or another. We feel that the whole package is important and how best to do that. So welcome any suggestions.
Speaking of which, I can read some in the chat room. Great idea of incorporating the fall bingos into group lunches via band councils and seniors workshops. And I believe you asked who should be involved, and somebody answered Saskatchewan First Nations and Métis Health and Wellness Research Network should be considered.
Great.
And someone said they respond better to people they have a good relationship with. So community development and working on building those relationships would be the place to start. Touting your program when you are a stranger to them isn't going to work.
Right. I absolutely agree. Yeah.
And Kara provided a website, which, by the way, we're going to get a copy of all those notes in the chat room, Vicky. Hint, hint, Michael, we're going to need that. Somebody mentioned First Nations Health Authority in BC.
Mm-hmm.
And somebody said, it sounds as though you are doing some really great work. I strongly discourage you from adopting a pan-Indigenous, pan-Canadian approach. It is not an approach that is welcomed by Indigenous people. Happy to chat further about the reasons why and how to best engage First Nations leadership at a national level. This coming from my many years of working with First Nations at a community, regional, and national level.
I would definitely like to follow up. I hope we have a contact for that person.
Julian, Julian M, we're inviting you to put your email address in the chat room because we'll copy and paste.
And that can be done privately. I think there's a choice of who you share.
Yeah, okay.
Yeah.
That can be done too. Perhaps another
I can give my email.
Okay, well, I hope you have it at the end, Vicky, so we'll make sure you give your email in the chat room. Another comment is perhaps we should approach our local connections for interest and awareness to start. Age-friendly community groups, friendship centers, BC's FNHA community band, and health councils leverage our relationships. And some people mentioned maybe local friendship centers, partner with already community programs that have the fall prevention services already established. Elders will always come out to birthday celebrations, maybe having elders 6 months birthday celebrations that include elder fall workshops. This would incorporate respect and honor for elders.
Nice.
And do the elders know that falls are an issue in the community? This is very important so that collaboration can start and programs are more meaningful. Really love the idea of First Nation sale.
Great. God, I wish we were all in person so I could talk more. I have another question.
Oh,
So how can we
before you
adopt?
go, Vicky,
Yep.
before you go, somebody did ask you a question back.
Okay.
Could elders and senior community members be co-leaders for training?
Oh, absolutely. Yes, and that's a wonderful suggestion to build more on that. Yes, that did happen in some communities, but more of that. Absolutely, that's a good idea. So the second question, how can we adopt a coordinated and innovative approach to fall prevention for older adults in Indigenous community that maintains social and cultural connections to the land? That was an issue that I heard often, and I don't know that we have done that well.
And while people are typing, Vicky, I just want to attract your attention to the fact that people wanted maybe if you could cut and paste, although I've been told that we cannot cut and paste. The participants cannot necessarily copy and paste from the chat room, but they wanted to know maybe if you can put the video link again in the chat room.
Oh, to the motivational Tai Chi video? Yeah.
Yes.
Okay. I'll do that at the end. Yeah.
Okay, great. Oh, somebody did that. Thank you,
Oh,
Karen. Thank you, Karen.
Brilliant. Yes, I do encourage you to watch that video. And I just want to emphasize that, you know, with this work, I very much realize that I come from the colonizing community. And it was so important that I be invited into the communities, that I work with locals, that I take their leadership and follow their guidance. And I realize how important that is. I would love to see all of this transferred over to people who live in the communities and do this work. So just want to acknowledge that.
Okay, haven't seen comments.
Okay, I'm going to pose the next question then, Elaine. Okay. How can we build local capacity for well-equipped, well-informed Indigenous health and community service providers for fall prevention? And one of the main things I was hearing in the really remote communities was a lack of high-speed internet and just how that limited their ability to connect. And I know there's been some talk provincially or federally about this happening, but I just can't emphasize the need to get everybody at the same level to be able to communicate and how important that is. And any way we can speed that up on the federal government side and First Nations communities and Indigenous communities across the country, that would be wonderful. But any ideas people have, please let me know. And I'll just pose the last question just to wrap this up. And how can we build the capacity for external health and community service providers to be sensitive of the needs and cultural safety of older Indigenous people? And for me, it was so important to take cultural sensitivity training. A number of times I have taken opportunities for this, and how much I have learned here in BC. I have not seen a program that for other communities, but I'm sure there are some. But so important to understand the context and the cultural beliefs and traditions.
So Vicky, there are a few comments, and I want to remind people that this session is a little bit longer than an hour, so we're not limited to the hour, as there is another presentation. So one comment, Vicky, is, as you mentioned, key stakeholders are important to start the conversation to implement a fall prevention program. We need buy-in from local health centers, chief and council, EMS, etc.
Yeah, EMS is important. Emergency medical service, absolutely. Yeah.
And somebody else said, I also think intergenerational fall prevention programs are helpful, as many elders are caring for their grandchildren. As they learn about helping to prevent childhood falls, they learn about preventing their own. Addressing smart choices about smart outdoor adventure play is a great way to integrate a grounding environmental approach.
Wonderful suggestion. Thank you for that. I just want to acknowledge the work of Dr. Fabio Feldman and his team in the Fraser Health, who have developed the Superheroes Fall Prevention booklet and elementary school program, where they work with the youth on helping their grandparents reduce fall risk. And I believe that was going to, I don't know if anybody here is from Fraser Health Online, but I believe that was going to be adapted for Indigenous populations. I don't know if that's happened, but it's a wonderful program and it really does bring the generations together. So that's a wonderful suggestion.
And our super participant, Karen Brown, has put the link in the chat room. Thank you, Karen. You're fantastic. Keep the link to the Safety Superheroes
Oh,
resource.
well done. Oh boy, great people online. This is wonderful.
Yes.
You ask and it will be provided.
Any other comments that you want to, suggestions you want to make to Vikki, or answer the questions that she has posed? Vikki, maybe you can type in the chat box, your email address. So I don't know if you have it on your slide somewhere at some point.
Yeah, while I'm in this mode, I don't see the option of going to the chat box while I'm in the presentation.
Oh, I see. Okay, so you can wait until you're done with your presentation, and then when I'm sharing my slides, you can do that.
Well, you know what? I'm done.
You're done? Okay, so now you have to unshare.
Okay, but before I do that, I think you wanted me to talk about the last fall prevention conference in St.
Yes, but
John's,
before you do
Indiana.
that, there's one more comment.
Okay.
I have found that for many First Nation elders, exercise for the sake of exercise is not part of their tradition. Incorporating exercise into other community activities, such as those related to hunting, fishing, berry picking, tanning, beading, sewing, wood gathering, etc., seem to be more motivating for seniors, but require significant support from the community.
Right. Yes, yes. And I've certainly heard that before, and it's a wonderful suggestion. Is getting back to the land and incorporating it into, berry picking or hunting or anything that would have people do what they do traditionally. Exactly. Yes, yes. And to learn how that can be fit in. And I think the earlier comment about maybe there is no desire for a pan-Canadian version. I'd like to learn more about that and maybe how we can have a program that can be adapted. And because there's a great variation in cultures and traditions and ways of being on the land. So absolutely. And I'm just putting my email in here.
Perfect. And after you've done that, you may want to unshare your screen. We still see your screen, and I'll let you do, I was about to ask you for a third thing at once, so just see how multitasking you do.
Okay. The panelists and attendees, and I think that's
okay.
it. And so stop share. Okay.
Okay, perfect. And now you can maybe talk about giving a link to what I'm going to be talking about. So if you want to start as to how the fall, the Indigenous Fall Prevention Network came about.
Great, I will. Thank you. So with the help of the Public Health Agency of Canada, we were able to hold a summit in conjunction with the Fall Prevention Conference in St. John's, Newfoundland 2 years ago. And that summit was very well attended, actually internationally attended. We had people from China and Australia and the United States. It was very well attended. It was wonderful. And at that summit, we had key speakers from Australia who came in person to talk about what they're doing with the Aboriginal communities in fall prevention, and a number of other speakers from across Canada and elsewhere. And just to say that there is quite a bit going on with fall prevention, and yet there are struggles and there's a lot of learning. And so we shared that, and on our website, and maybe we could put this up too, the CanadianFallPrevention.ca. So it's just Canadian Fall Prevention, all one word.ca. There is a link to the video of that conference and all the presentations. So I do encourage you to look at it. But that really was the first big event to really launch what's been requested by the Indigenous populations to look at falls among their elders, to really bring us all together. And out of that, with the help of Elaine's group, a Neurotrauma Foundation, and the community of practice, the Loop, as it's known, we now have an Indigenous fall prevention network. So the people that attended that summit wanted to go on talking about this issue, working together and making connections. And so I do encourage all of you who have an interest in this area to join the Indigenous Fall Prevention Network group. It's a private group, but you just join by going to the Community of Practice Loop website under private groups and sign on. And we have meetings every 2 months or 3 months, Elaine?
Every 2 months, but I can speak to that now.
Okay, now I pass you over to Elaine, and thank you all so much for your input and suggestions. And I look forward to going over those more carefully after this is over. So thanks again to everyone for being part of this.
Great. And don't go anywhere, Vicky. I'm sure
Okay.
you can chime in as you wish. So I'm just going to give you an overview. As some of you may know, Kathy Belton could not make it today. She's the other co-chair with Vicky for the Indigenous Fall Prevention Network. But unfortunately, she was not feeling well today. So I want to introduce the vision and mandate. We've been meeting for at least 2 years now since the conference, as Vicky mentioned, and have come up with a consensus on the vision and mandate that we see for the network. And we'd like to see healthy and safe Indigenous adults and older adults. That's the vision. And how to do that is to facilitate a collaborative process for fall prevention guidance, strategic directions and support to practitioners, community leaders, and other key stakeholders working with Indigenous adults and older adults in communities across Canada. Of course, we thought that it was very important to talk about our guiding principle in that network, and definitely respect for the autonomy of Indigenous adults and older adults and their cultural, spiritual, physical, and emotional needs. And we also thought that the processes and outcomes of the network will be those that demonstrate the importance of treating Indigenous adults and older adults with thoughtfulness and respect. So initially when we met, it was right after the conference, and all of us were wondering, like, who's got which information and resources. As Vicky pointed out, there are various resources out there, but not necessarily known to everyone across Canada. So our first main objective was to sharing existing fall prevention resources that are out there and that do work with Indigenous communities. And it's still a work in progress as we're doing that. But out of that as well, we thought, well, there's going to be some obvious gaps that come up. And we should also be a network that aims to develop resources that address those gaps as well in fall prevention for Indigenous adults and older adults and across Canada. So resources that can be, if possible, as a comment was made earlier, that could be used by several Indigenous communities. And also, because we are a network that's growing, we would like to be informing and influencing policy and tackling emerging fall prevention issues with Indigenous communities collectively. And how can we move this forward? So coming back to what Vicky was mentioning, so it's open to everybody who's working with Indigenous communities, and also who have interest in providing and working with Indigenous communities, and they may not have services right now. So it's an open network. We encourage active participation. So if you have resources or have some expertise, to share it with the group. The members are liaisons between the network and their organization and regions. So if you learn something, bring it back to your organization. And as I mentioned earlier, we meet every other month by Zoom, similar to this. And but in between, we do have the connection through the community of practice. And my organization, as Vicky mentioned, supports and coordinates this work. So the Indigenous Fall Prevention Network is located on Loop, the Fall Prevention Community of Practice, which is a free bilingual online platform, but it is as a private group. So we wanted to do it as a private group because, first of all, not everybody might be working with Indigenous communities, and it felt like it was a safer space, and to make sure that we would know each other, because at the moment I think we have about 60 members in the network. So the co-chairs, as I mentioned earlier, are Vicky and Kathy. And to join the network, here's the link for a Loop. And then you have to click on the link for the Indigenous Fall Prevention Network. You just make a request and we'll let you in. And this afternoon, if you want to learn and get a little bit of a tutorial on, if you're not familiar with Loop, Shamiza will be offering that. She's in charge of Loop, and she'll be offering that this afternoon at 3. Any questions? Comments?
Elaine, I'll just add, am I still on? Yeah.
Yes, you are.
Add that once you sign up, there are many different categories where our resources are posted. So you have a lot of information posted about the Fall Prevention Week, is it, or month?
Month, yeah.
Month. And then under education, there are different links. Under research, there are different links. So there's a lot of resources posted on the site as well as those that are shared at each meeting.
Yes, and that's a good point, because the network allows us to have conversations within that space as well. And Vicky was instrumental in posting several resources of hers and others. And we do also, I know, Vicky, earlier you mentioned the proceedings for the conference. That's also posted there as well, the links. So everything, if you want to find all the resources that we know of around fall prevention for older adults and Indigenous communities, are there. So, but we always encourage people to post as well.
And you know, I think there are some people online who are in the policy field for Indigenous health, and we really encourage those groups to be part. You know, how can we make fall prevention available, all the resources available more widely? How can we learn about more that exist? How is fall prevention part of health promotion initiatives? How can we weave it in? If you're going into a community, or if you are part of a community and you're introducing health promotion, how can we weave fall prevention into that? Be it, you know, a program about diabetes or home safety or whatever. How can we work together to spread what is known and what works?
Yeah, Vicky, you may want to be seen as well when we're chatting.
Oh, okay. There we go.
Yeah, not just me, the two of us. Perfect. Do people have questions and comments either for Vicky or myself?
Let's see, a question posted.
No, not yet.
I think you've answered those questions.
Yeah, we answered the questions on your presentation.
Oh.
Okay. Is there anything else you'd like to add, Vicky, before I do the closing comments? Oh, there's a question. Wait a minute. Do you have any technology partners? Do you mean in the network or with Vicky? Vicki, maybe you can answer with your program.
Well, by working with the University of Victoria, they've been incredibly generous in helping us get other fall prevention programs online. But as I mentioned, I think one of the biggest challenges is the ability to take online courses if you have low bandwidth and live in the remote communities. And once again, that goes back to the federal government, I think, to make that happen, or is it local governments in partnership? But you know, I hear talk of that, but I want to emphasize the particular need for at-risk communities to be seen as a priority in getting that service.
Great. Any other questions? No?
If anybody would like to be on the list for notifications of new courses or other programs, you know, I did put my email out there. Please let me know.
And as a practice, Vicki is very good in putting those ads in loop as well. When the programs come up, she advertises, she lets people know that the course is up. So you can find that there too. Okay, so well, I want to thank everyone for joining us for our first presentation of day 4 of the Canadian Fall Prevention Virtual Conference. Please ensure, don't go anywhere. Please ensure that you complete the post-presentation survey. It's going to come up right now. And we'll see you back again at 3 p.m. Eastern for our second set of presentation today. Thank you, everybody.